Thank you. Good afternoon, all. Today's my topic is impact of smartphone use and forward head posture on temporomandibular disorder symptoms across sectional study. Moving towards the introduction. Smartphone use has become an integral part of daily life, particularly amongst the young adults, with prolonged screen time increasingly associated with altered head and neck posture. Inappropriate neck posture while reading or texting on a personal computer and cell phones leads to manifestation of a complex cluster of clinical symptoms commonly defined as the tech neck syndrome. Neck pain in general is a global cause of disability. It is a public health problem that has increased remarkably nowadays. The prevalence independent of age is high and equal to low back pain. Epidemiologically, data indicate that 73% of the university students and 64.7% of people who work from home have neck or back pain. 39.2% of them admit to begin less productive due to neck or low back pain. When we're talking about the causes, due to being at the or computer long hours at a desk, or the bending of the body and the lack of movement and stretching, or you can say the physical activity. When we're talking about symptom, pain in the neck or upper back or shoulder region because of the forward posture, headache, reduced mobility, increased pain with the neck flexion. And this posture, along with the prolonged daily usage, may contribute to the increased mechanical strain on the cervical and masticatory musculature. This consists with the observed high prevalence of the self-reported TMD symptoms in the several international studies. So this posture increased load on the TMJ causes hyperactivity of the masseter and temporalis muscle, aggravate bruxism, restricted mandibular movements and clicking, contribute to jaw pain and headache. So all these with the cervical, spine and masticatory muscles are functionally interconnected. Therefore, the posture alteration may influence the mandibular position and muscle activity. Simultaneously, TMD disorders are rising among the students. So the aim of this study to explore the association between the smartphone usage and the temporomandibular joint symptoms. So the aim of this study to find the association between smartphone usage and posture and the temporomandibular disorder symptoms among the young adults. And objectives are to measure the average daily smartphone screen time amongst young adults, to assess common smartphone use posture pattern, and to determine the primary purpose of the smartphone use. After the ethical committee approval, this study conducted amongst the young adults aged 18 to 30 years who use the smartphone daily. Participated who are willingly to participate were included in the study, while individual with a history of facial trauma, ongoing orthodontic treatment, previous TMJ surgeries, or systematic disorders affecting muscles or joint will be excluded from the study. Data was collected using a structured questionnaire covering demographic characteristics, smartphone usage pattern, posture-related factors, and TMD symptoms, and potential modifying factors. The primary outcome was the presence of TMD symptoms, while the secondary outcome was include symptom severity and its association with the smartphone use and posture. Moving to the results, the first table show the demographic data in which we can see a total 120 number of participants were included in the study. Majority belongs to the age group of 21 to 23 years age, followed by the 24 to 26 years of age. Female predominance is noted. When we're talking about the TMD symptoms, or you can say the variable, jaw pain is very common, followed by the clicking and bruxism. The table 3 showed the daily smartphone usage by the participants. So the usage of the weekdays, or you can say the hours, is mostly the 3 hours in a weekday or also in the weekend. When we're talking about the duration of the smartphone use, Majority of the participants reported the moderate to high usage of the smartphone, which is 4 to 6 years. Regarding the posture, slight neck flexion was most common position, followed by the marked forward position, and the normal position is very less amongst the participants. When we ask the primary purpose of the smartphone use, the most of the participants use the phone for the various purpose, mostly the social media, academics, gaming, and video streaming. The table 7 shows the association between the smartphone posture and the jaw pain intensity. So there is a positive correlation between these two. Now moving towards the discussion, the present study evaluated the association between smartphone use and smartphone related posture and self-reported temporomandibular disorder symptoms among 120 young adults. The majority of participants belongs to 21 to 23 years of age group, followed by the 24 to 26 years of age group. With the average age was 25 years with a clear female predominance of 80%, which is similar to Atkal HG. In his study, he mentioned the same age and gender. Self-reported TMD disorder symptoms among the study participants, the jaw pain was the most common reported symptoms, followed by the clicking and popping sounds, which is accordance with the study by the Iqbal et al. Majority of participants reported moderate to high smartphone usage on weekdays and weekends. In terms of duration of use over years, the largest portion of the participant has been using smartphone for 4 to 6 years, followed by 7 to 10 years. Whereas other authors found the usage of this smartphone is more than 6 hours per day and for the 6 years. The present study was the predominance of non-neutral smartphone posture. Slightly neck flexion was reported by 65% of participants, followed by the forward head posture, and very less with the normal position. More than the half of the participants reported using their smartphone while lying down frequently, which is accordance with the other authors. This pattern indicates that the smartphone is used frequently accompanied by the sustained cervical flexion or forward head positioning. Such posture may alter the biomechanical relationship between the cervical spine, head, mandible, and the masticatory musculature. Increased activity and fatigue of the cervical and shoulder muscle may potentially influence the function of the tromogenic system through the close neuromuscular relationship between the cervical and the masticatory region. The predominance of the social media, academics activity, and the video streaming as smartphone-related activities indicates that the smartphone exposure in young adults is multifactorial. These activities often involves a prolonged period of the visual attention and limited posture variation. Therefore, interventions aimed to reducing the potential musculoskeletal consequences should focus not only on the reducing total screen time, but also on promoting ergonomic smartphone use, maintaining the device closer to the eye level, avoiding prolonged neck flexion, taking regular breaks, and maintaining appropriate head and neck alignment. Participants with the forward head posture and the slight neck flexion reported higher as proportion to the mild to moderate pain compared to those maintaining a neutral position. The analysis demonstrated that a statistical significant association between the smartphone posture and categorized jaw pain intensity. So I conclude the present study highlight the growing concern regarding the potential impact of the smartphone usage and the non-neutral head and neck posture on the TMD disorders amongst the young adults. These findings emphasize the importance of promoting ergonomic smartphone usage, including maintaining the smartphone closer to the eye level, avoiding prolonged neck flexion and forward head posture, taking regular breaks during the extended smartphone use, avoiding prolonged smartphone use in awakened position, and particularly while lying down, encouraging awareness of correct head and neck and body posture. So the smartphone are essential in modern life, but how they are used may be as important as long how they are used. Promoting healthy smartphone posture may help reduce cervical strain and potentially minimizing the risk of aggravation of the temporomandibular disorder symptom. These are thank you.
Thank you, Dr. Smriti. I would now like to invite Dr. Panna Dave ma'am to kindly take up the questions. Over to you, ma'am.
Yeah. Hello, Dr. Smriti. It was a nice presentation.
Good afternoon.
But what I would like to ask is, yes, the use of smartphone is related to the neck pain and the TMJ, but you had mentioned that there was a female predilection. So is there any specific reason, or because of your sample size you got that finding?
And because of the sample size, and also we know that the TMD is more common in the female patient. Both of them.
Okay. Okay. Thank you.
Thank you, ma'am. With this, I would like to call my next presenter, Dr. Rucha. Dr. Rucha, you can unmute yourself and can you share your screen for the presentation?
Yes, ma'am. Very good afternoon. The title of my paper is Correlation of Fractal Dimension Analysis with Bone Density on CBCT at Pre-Implant Site, a retrospective study. So the success of dental implant depends on various factors such as osseointegration, the what type of implant material we use, the the general health status of the patient, the quality and quantity of the bone tissue, implant surface, and the surgical procedure. So my study depends upon the quality and quantity of the bone tissue. So as we all know, DEXA scan is considered as the gold standard for evaluation of bone mineralization. However, in dentistry, we commonly use CBCT to assess the quality of bone. So there are different classifications like ZARC classification or MISH classification, which we commonly use to assess the bone quality. But here the clinicians have difficulty in quantifying the bone density. Therefore, the present study was conducted. So fractal analysis is one such method where we can determine the pattern and complexity of such structures quantitatively, which according to some researchers could be a diagnostic tool to characterize the alveolar bone. So I have mentioned what are the stages of fractal analysis. First, we take a section of interest, then blur that image, then subtract the original image. Then we add a gray value, erode, dilate, invert, and then skeletonize the area of interest. So the present study was to calculate the fractal dimension analysis on CBCT scan of an edentulous site and correlate it with bone density determined using the MISH classification. So the inclusion criteria of the present study was CBCT images were taken of 85 patients. The age range of the patients was between 18 to 40 years of age. And exclusion criteria was CBCT scans over the patients of above 40 years of age, and the patients who were under some drugs affecting the bone density with systemic diseases such as diabetes, osteoporosis, and developmental anomalies. So CareStream imaging software was used with a 90 kVp, 2.5 mA, a scan time of 15 seconds, and field of view of 8 into 5 mm, 5 centimeter. And bone density was evaluated using the MISH classification. There are a number of softwares which are used for fractal analysis, out of which the easily available is ImageJ software. So this was used in our study. So this is the method how the fractal analysis was done. The region of interest was selected manually in the edentulous site where the future implants were placed, and FD analysis was performed on the region of interest with the box counting method. So in this image, mental foramen was marked as perpendicular to the computer screen. Then the cutting curve was drawn on the center of the axial image of mandible, and the area of interest was selected, which measures of 40 into 40 pixels. Now, this was the image processing method which was used in ImageJ software, that is duplication, then applying the filter, then subtracting the initial image, converting it into 8-bit image, and then skeletonizing the image. Coming to the results of the study, in present study, 85 of the CBCT images of the patient between the age group of 18 to 40 years with a mean age of 31 were included. Out of 85 CBCT images, 42 were males and 43 were females. So the FD value was higher in D1 category, followed by D2, D3, and D4 category. The difference in fractal dimension was correlated according to the MISH classification, and the comparison was found to be significant with p-value less than 0.001. When intergroup-wise comparison was done, FD value in D1 category was significantly greater than that of other 3 categories, and the FD value in D4 category was significantly lower than all the other 3 categories. The differences, the mean difference is shown in in table 2. Coming to the discussion, there are studies which show that CBCT can be used to assess the bone density. A study carried out by Parkinson et al. Showed that this regarding bone density assessment was done using CBCT and CT, which showed that bone density values were generally higher for CBCT, but even though the CBCT and CT values can be correlated, therefore CBCT can be used to assess the bone density. Then there was one animal study which was conducted to find a correlation between the fractal dimension and bone density, and the study suggested that bone density and fractal dimension increase simultaneously. Then another study was carried out in 2022 by Jolly et al. It showed that fractal dimension is a reliable method in analyzing changes in the alveolar bone density in various bone categories. However, they concluded that the FD dimension differentiated between women with normal BMD and osteoporosis at the mandibular site. The reliability was low. Another study conducted by Onem et al. Measured that fractal dimension around the implant site was found that FD values of implant-bearing bone following the initial healing was lower than alveolar bone surrounding the contralateral teeth, but the difference of this was not significant. Another study conducted by Pala et al. Showed that lower bone density in the edentulous site than in dentulous region. Another study conducted in 2021 investigated the application of fractal analysis as a predictor for determining osseointegration of dental implants, and result shows that FD values gradually increased after first week but did not exceed the baseline values. So there are numerous studies, but what is the novelty of our study? The fractal dimension is being evaluated specifically at pre-implant dentulous sites on CBCT. The study uses CBCT images of the edentulous patient planned for implant placement rather than relying on panoramic and periapical radiographs. In this study, MISH classification was used, but it is essentially a qualitative and subjective grading system, the present study attempts to determine whether fractal dimension can quantitatively differentiate these 4 bone categories. The limitations of the study are a smaller sample size and comparison with only just one classification. Therefore, more studies with larger sample size and comparison of the results with various methods should be performed to determine the reliability of the results of the present study. The conclusion: fractal dimension analysis is a non-invasive, cost-effective, quantitative method that could be helpful in assessing the bone density in dental implant placement site compared to traditional qualitative method of assessing the dental implant site. Thank you. These are my references.
Thank you so much, ma'am. Now I would request Dr. Pannadave ma'am to kindly take up the questions.
Hello, am I audible? Yeah. Hello.
Yes, ma'am.
Yeah,
Yes, ma'am, you're
I
audible.
wanted to ask that is this method quite easy? That
Yes,
you're
ma'am, very
telling?
easy.
Is it being employed on a regular basis in your practical, I mean, in your college or your institution for all the implant cases, or it is only a study which you have done and you have come up with some kind of a conclusion?
Ma'am, right now we have just finished the study, but maybe for the future cases we can apply this method.
At present, you haven't applied the fractal dimension for your cases as such. It's only
No,
the
ma'am.
study part you have done. And in case you had mentioned something about osteoporosis, which I missed a little bit. So, in patients with osteoporosis or other bone disorders, you can still use it.
Yes, ma'am. So, ma'am, there are various studies carried out on just fractal analysis in different, like a postmenopausal woman and various bone disorders is being tried. But in our case, we just tried for the implant placement.
The implant placement, but you did not judge how much osteointegration has taken place.
No, no, no.
Okay, thank you.
Thank you.
Thank you, ma'am.
I would like to invite my next presenter, Dr. Preeti Chahal ma'am. Over to you, ma'am.
Okay, just give me 2 seconds. I'll just share my screen.
Okay, ma'am.
Share screen. Actually, I have joined this using my browser. So there's something, some technical glitch. I'm not able to share my screen. I don't know. Am I audible?
Yes, ma'am, you're audible.
Can you help me share the screen, because I'm not able to. I've just joined this conference using my browser instead of this from my laptop. So I don't know. There's some technical glitch. Just trying.
We make code easy to connect.
Ma'am, can I present in the last? I mean, can we ask the next presenter to present, and I'll present at his or her place. How do I do that?
Okay, ma'am. Till the time you're figuring it out, we'll call our next presenter. That is
yes.
Dr. We'll call our next presenter, Dr. Monal Kakkar, ma'am. Ma'am, can you please unmute yourself and kindly share your screen?
Just doing it.
Over to you, ma'am.
Hello, Dr. Preeti ma'am. What are the issues?
Preeti ma'am is not able to share her screen right now.
Okay. Then next presenter.
I would like to call Dr. Monal Kakkar, ma'am, to kindly present her presentation. Dr. Monal, am I audible?
Call it another next presenter, Madhu.
I would like to call Dr. Madhu Nagesh to kindly present the presentation.
Yeah, good afternoon.
Over to you,
I
sir.
can actually. Just give me a minute.
Okay, sir.
Can I share my screen?
Yes, sir, you can.
Okay. Is it visible now?
Yes, sir.
Okay, great. Am I audible?
Yes, sir.
Thank you so much. Good afternoon, everyone. And I would like to, first of all, thank the organizers for inviting me to present. This IDDCON is a wonderful idea, taking dentistry to all the remote areas of our country. So it's a great initiative. I congratulate the organizers. So I'm Dr. Madhu Nagesh, consultant facial-maxillary surgeon based in Bangalore. I'm also an emotional intelligence coach. So the topic of today is beyond burnout, emotional mastery and resilience for dental professionals. So I thought this is a much needed topic today. I interact with established clinicians, people who are just starting out. I also coach corporate clients, high performance corporate clients. So what I've noticed is all of us have certain emotional patterns we run. And over a period of time, this constant emotional pattern we run leads to burnout. So what's burnout? A sense of overwhelm. Oh, it's too much. Things are too much. I can't handle it. So before we get to that stage, there are certain things we need to do. So what we are seeing is in clinical setting, a lot of us are facing decision fatigue. We have to make multiple decisions throughout the day, whether it's in response to the patient or family, a lot of decisions. So that's called decision fatigue. So what's happening is there is information overload, too much information coming at us. And sometimes we are not able to handle it. That causes overwhelm. We don't know what to do. So let's see what are the tools we can use to minimize this, to prevent this, and possibly reverse this. So the next slide. Okay, so emotional intelligence is a concept introduced by Dr. Daniel Goleman No, I work with Professor Goldman. He's been called the father of emotional intelligence. So what's actually emotion? What is emotion? Emotion, you can say, it's a powerful thought. It could be positive, it could be negative. Most of the time, the human brain is designed to react in a negative way. So most of the time, if you notice, your thoughts, your emotions will tend to be negative. So we have a negativity bias, so to say. So how do we change this negativity bias? That's what we'll learn. So why this burnout is happening more now compared to earlier days? As I said, too much demands, clinical responsibility. You need to care for patients. You need to make sure they're getting the best treatment. You need to manage your finances. You need to manage your clinic. You need to manage your family. And of course, you need to commute, especially in India, commuting can be a big hassle. So there is an emotional overload. There is repeated decision making under stress. There is also a patient expectation. Nowadays, patients turn to AI, chat GPT. They think they know better some of the times. So that causes an additional stress. Emotional demands from the family, from your colleagues, and of course, from the social media. We all use social media. And what happens when we use social media? There is always a comparison. Oh, that colleague is doing better than me. Oh, that colleague has got 2 clinics. Oh, that colleague has the latest car. So this comparison again fuels emotional reactions. We feel we are just not enough. So social media is adding to this burden. So what's the goal finally? The goal is to prevent the depletion of our resources. So at the end of your clinical day, you do not want to feel overwhelmed, burnt out, no energy. At the end of your clinical day, you still need to be energetic so you can fulfill your responsibilities as a family person, maybe go out somewhere. So we do not want this emotional burnout to carry on to the family side. So what are the tools we can use? First of all, identify any trigger or any stimulus which comes to you. It could be positive, it could be negative. Let's say a patient whom you have been treating for some days comes back and says, Doctor, your treatment failed completely. I'm not at all satisfied. So that's a trigger, that's a stimulus. So when the patient tells you, Doctor, I'm just not satisfied with your treatment. So there are two things happening. One is happening in your mind. Your mind is telling, oh, what did I do wrong? Is it really true? Or is this a difficult patient? So when you're processing that, there are certain emotions. You may have guilt. You may have, why is this patient being so difficult? And you may reject that criticism. So the thought and the emotion together create something called a mind-body response. Usually what happens is, whenever you have a negative thought, negative emotion, the body constricts. Your jaws tighten, your body tightens, your breathing becomes shallow. You may have noticed this sometimes. And different people have different responses, depending upon what sort of a person you are. The same trigger, what I told you, patient coming back, with a complaint, two different clinicians will handle it completely differently. One may get overwhelmed. One may be very calm and say, okay, let me see what I can do. So you have to determine how your emotional responses to this happen on a daily basis. So repeated stress can make emotional responses increasingly automatic. So sometimes without our knowledge, it's happening automatically. Traffic jam, you get stressed out. Traffic jam, negative emotion. Patient turns up late, emotion, negative emotion. So this pattern you need to recognize. So the key to managing this is awareness. You need to become aware. Am I running a particular pattern here? Am I always reacting in a particular way? Is my emotion always negative? Can I change this? Awareness is the key, and it takes practice. So become aware of what is the constant emotional reaction you are having on a day-to-day basis. So what I would advise is at the end of your day, at the end of your clinical day, have a journal, write down what triggered you today, what triggered me today, what was my response. Just make an emotional audit. At the end of every clinical day, just make an emotional audit. Okay, today that patient was difficult. Maybe my reaction was a little bit irritable, or maybe my reaction was positive. Just make an audit of that and see the pattern. Are you repeating the same pattern? Just make a note of it. One more thing you can do is stop, breathe, observe, proceed. Stop, breathe, observe, proceed. So when you get that urge to react, just stop for a while, just pause. Take few slow, deep breaths. Take few slow, deep breaths. As you breathe in, let your stomach and just expand. As you breathe out, let your stomach go in. Breathe. Observe for a few seconds what's happening. And then you proceed with the reaction. So don't immediately react. Take a slow, deep breath. Breath is one of the most powerful and simple tools we have. Pause for a while before reacting. That pause gives you all the power. That pause gives your power back. So you can think, am I going to react in this way? Am I going to react in that way? Just a few seconds of pause helps. Then we also have a 4R framework. We call it reset, release, reframe, reconnect. Reset, pause, release, acknowledge that you're having a negative emotion. Just name it. Oh, I'm feeling irritable right now. Oh, I'm feeling sad right now. Acknowledge it, release it. Reframe it. Reframe that emotion from negative to positive. And reconnect, most importantly, reconnect with your true purpose. Why are you a clinician in the first place? Go back to the purpose why you became a doctor or a clinician or a dentist. So reconnect with that purpose. I became a clinician to serve patients. So that's your core principle. So you're doing your everyday job towards that. So reconnect with your purpose. And one of the most powerful interventions is the breath work. It's always available to you. Most of the time, we don't even know that we're having shallow breath. So when to use it? Before a procedure, before a difficult procedure, just take a pause, do slow, deep breathing. When you inhale slowly and deeply, your heart rate comes down. Your mind becomes calm. And when you're in a calm state, you can always make better decisions. So breath is very important. So it's not to force calm, but to create a space for regulation and intentional response. So slow breathing, slow exhalation, and become aware of how your body is reacting. So this is always available to us. The problem is, we forget to do this. In the midst of our hectic day-to-day clinical practice, we forget to pause. We forget to breathe deeply. We forget to reconnect with the original purpose of why we became clinicians. So use breath work as a micro intervention. Build daily emotional fitness. Mornings before you start your clinical work, just decide how you want your day to be. Do you want it to be smoothly flowing in spite of all the things which can go wrong? Then midday, make a midday reset. Take a pause. Okay, how did my morning go? How do I want my afternoon to be? Were there any difficult patients? Was I able to respond appropriately to the patients? Was I able to respond in a caring way? Or was my own irritation coming out and maybe I did not respond appropriately to the patient? There are no difficult patients at all. So we cannot use the term, this patient is difficult. No, the patient is not difficult. It's your state of mind, it's your perception which makes us say this patient is difficult. Okay. So patients are there, because we are a authoritative figure, we are clinicians, and they're there to seek care. They just need to be heard. Hear them, listen. The art of listening is very important. So because We might be in an irritated state sometimes. We stop to listen. And even if we listen, we are listening to the wrong things. We are interpreting it in a wrong way. So listen deeply, listen passionately to the patients. Really get to know what they really mean. End of the day reflection. I told you, make an emotional audit at the end of every day. Make a book. This is very powerful. Even I do this. What went wrong? What irritated me? How was my reaction? What could have been better? So when you make an audit, you'll notice certain patterns. And these patterns are very powerful. They help you reframe your responses. Recovery rituals, yeah, breath work is one. Maybe do some stretches just before you leave the clinic. Stretch your body, do some simple stretches, do some slow, deep stomach breathing. Then you leave the clinic so that, when you get home, you're in a different state of mind. You do not want to take your clinical problems, your clinical stress to the family. And you do not want to get your family stresses to your clinic. So this is very important. Separation of the personal life, professional life. That's the key. Most of the time we carry, professional burden back to family, the family burdens back to the clinic. That's how we get overwhelmed. So what is emotional resilience? The ability to manage stress in an effective way. Stimulus is always happening, input is always there, but you need to manage it in an effective way. So you have to recover from that stress as soon as possible. You have to be in a state of mind which is relatively calm. So the aim is to perform at your best without losing yourself, without getting overwhelmed. So what it supports empathy, it supports clarity, communication, and sustained attention. So the clinician's emotional mastery practice: first, notice your patterns. Then name your emotions. I'm irritated, I'm angry. Regulate through breath work, become aware, reframe it. Then you respond intentionally, consciously, and always reconnect with your true purpose. Why did you become a clinician in the first place? To make a difference in this world. Always go back to that core purpose of yours. You are here to make a difference. You are here to build a beautiful society. You are here to treat diseases. You are here to cure pain. So when you reconnect with your purpose, with your passion, that's when you don't get over. And with this, I leave you to think about how you can, in your own life, manage your emotional patterns. And if you want to, reach out to me, please do so. I do help clinicians avoid burnout. I give them the tools to avoid burnout. You can always reach out to me. Once again, thank you so much, organizers, for inviting me. This burnout is a much important topic for us clinicians, especially for caregivers, because we have an additional responsibility, to the society. Thank you so much. Namaste.
Thank you, sir. I would now request Dr. Vanadave ma'am to kindly take up the questions.
Thank you, sir, for a very beautiful presentation. As said, sir, I don't have any questions to you, but yeah, you have given a lot of inputs how to manage self and finally how to manage patients. But this is also applicable to academicians like us who will have to manage students also. So
Yes,
we
ma'am.
need to, and I think we are more stressed out at when we are managing student rather than probably where you all are managing patients.
Very
So
true, ma'am, because students nowadays are very distracted, is what I have found. They're
they're
very
very
distracted,
demanding, very
they're very
demanding,
demanding.
and and
Yes,
very difficult to explain them. So
yes.
one way your presentation was really, I mean, it has given us lots and lots of points. In fact, any other person also would like to ask anything, it will be good. But I thank you for your fine presentation, sir.
Thank you, ma'am. Thank you so
And one
much.
more thing, sir, in case you face such difficult patients, how do you manage, sir,
Yeah,
in your clinic?
it's a constant practice. It's not like you can master your mind in one day. Just become aware that Even I can lose my patient, but I don't stay in that state for long. I use breath work, I use self-talk to immediately change my state. You know, so
Yeah.
that comes with constant practice. So every day practice breath work, practice the pause, and again reconnect to your real purpose. Okay, it's one day, maybe bad day, it's fine. So it doesn't mean that every day can be like that. So some days
True.
will be bad for all of us. In spite of all our experience, some days things just don't go well. Just accept it, surrender to it. Okay, today was a sort of a bad day, but tomorrow will be beautiful. So that's the only way we can keep going without getting overwhelmed.
Thank you, sir.
Thank you. Namaste.
Thank you, sir. Thank you, ma'am. I would now request Dr. Preeti Chahal, ma'am, to kindly share her screen and unmute for the presentation. Over to you, ma'am.
Okay, I'm just sharing my screen now. Is it shared now? Is it visible?
Yes, yes, ma'am, it is visible.
Okay, okay. So, first of all, I'll just start with a sincere apology that since I delayed the presentation, and also I would like to extend my warm regards to my respected head of department, ma'am, Dr. Aparna Dave, ma'am. It's a great pleasure to have you, ma'am. And of course, I'll take this platform to thank ma'am for her constant support and guidance. With that, I will start my presentation. So my study is comparative morphometric analysis of normal mucosa, oral lichen planus, and oral squamous cell carcinoma. So oral lichen planus is a chronic inflammatory condition of the oral mucosa. Am I visible? Am I audible?
Yes, ma'am, you're audible.
I'm audible. Okay, okay. So, oral lichen planus is a chronic inflammatory condition of the oral mucosa, and multiple studies have shown that approximately 1% of patients with OLP will develop oral squamous cell carcinoma. And diagnosis of OLP is based on both clinical and histopathological criteria. Histopathologically, lack of mucosal dysplasia could be seen with superficial lymphocytic band-like infiltrate causing basal hydropic degeneration, and lichen planus, it may be cutaneous lichen planus may be a transient eruption, but oral lichen planus tends to be more persistent with long-standing inflammation. So, as a consequence of long-standing inflammation, the patients of oral lichen planus are believed to be at an increased risk of developing oral squamous cell carcinoma. So while World Health Organization recognizes oral lichen planus as potentially pre-malignant, the rate of malignant transformation remains unknown. And squamous cell carcinoma is basically a malignant neoplasm of epithelial tissue origin, exhibiting varying degrees of squamous differentiation as characterized by formation of keratin pulse and a propensity to early and extensive lymph node metastasis. The assessment of cellular and nuclear features is very important in the histological grading of oral squamous cell carcinoma. Now, morphometry and stereology, these are quantitative structural techniques which enable objective information to be acquired from sections of cells and tissues. And these methods have been applied to the studies of normal and abnormal tissues, including those of OLP and oral squamous cell carcinoma, and their objectivity may find applications in differential diagnosis and prognosis. So, morphometric evaluation of epithelial cells can serve as a useful diagnostic adjunct for early detection of oral cancer. So, the aim of the study, it was to compare morphometric features of normal mucosa, oral lichen planus, and oral squamous cell carcinoma. The objectives were the measurement and comparison of nuclear and cytoplasmic volumes and area of basal cells in oral lichen planus, normal mucosa, and oral squamous cell carcinoma. Also, measurement and comparison of spinous cell maximum diameter in oral lichen planus, normal mucosa, and oral squamous cell carcinoma. The methodology, basically, it was a retrospective study. Archived paraffin-emitted tissue blocks were retrieved. The sections were prepared and stained with hematoxylin and eosin. Sections were examined under 40x or higher magnifications. Cells were evaluated. Basal and spinous cells were assessed for cellular and nuclear morphometric parameters. The images were then analyzed using ImageJ software. And the parameters studied were the nuclear area, cellular area, and the spinous cell maximum diameter. In statistical analysis, the data was analyzed using microscoped Excel and SPSS 23. The results expressed as mean plus minus the standard deviation. One-way ANOVA for intergroup comparison was used, and Turkey post-hoc test for pairwise comparison. So this was my study flow. We had archived tissue blocks, did the sectioning, staining, followed by microscopic examination. The images were captured, and subsequently the morphometry was done, and then the images were put to statistical analysis. So once H&E staining was performed on paraffin sections, the measurements were made on basal and spinous cells, and the ImageJ software was basically used for individually cropped cell analysis. In this, now the observations, basically, the study was conducted on total of 39 cases, of which 13 were oral squamous cell carcinoma, 13 were lichen planus, and the remaining 13 were normal mucosa. The individual cells were cropped and analyzed by using ImageJ software for various parameters. The data set was transferred in Excel sheets, and the parameters which needed to be calculated were calculated using appropriate equation. Nuclear volume, the main nuclear volume was highest in OSCC group, which was followed by lichen planus, and least in the control group. The intergroup comparison of the three groups was done using one-way ANOVA. When the post-hoc analysis was done, the difference was significant between the control group, the lichen planus, and the oral squamous cell. Sorry, the control group and OSCC, the control group and lichen planus, and OSCC and lichen planus. So we can see this graph for mean nuclear volume. So it was highest for oral squamous cell carcinoma, followed by lichen planus, and least in the normal mucosa. Likewise for nuclear area. And now moving to the comparison of cellular volume, the new mean cytoplasmic volume was highest in OSCC group, which was followed by lichen planus, and least in the control group. The intergroup comparisons of the three groups was again done using one-way ANOVA, and the post-hoc analysis was done. The difference was significant between the control group and OSCC, control group and lichen planus, OSCC and lichen planus. Now, for the cellular area, the mean cytoplasmic area was highest in the OSCC group, followed by lichen planus, and then again least in the control group. So we can just see. Now, the observations and results again for the spinous cell maximum diameter, it was again highest in OSCC group, followed by lichen planus, and least in the control group. The intergroup comparison of the three groups was done using one-way ANOVA, and when the post-hoc analysis was done, the difference was significant between the control group and the OSCC, again the control group and the lichen planus, and OSCC and lichen planus. So we can see again the values are highest for OSCC, followed by lichen planus, and then the control. So oral squamous cell carcinoma, it is the most common malignant neoplasm arising from the mucosal epithelium of the oral cavity. And in the Indian subcontinent and in other parts of Asia, it remains one of the most common malignancy. And this is a paradoxical finding since most cases are preceded by readily detectable mucosal changes, most often red or white patches. The diagnosis of precancers is primarily based on clinical morphology and its grading in histology, that is dysplasia. The presence of epithelial dysplasia may be even more important in predicting the malignant development than the clinical characteristics. But the three major problems, however, are attached to the importance of epithelial dysplasia in predicting the malignant development. And they are, first of all, the diagnosis is essentially subjective. Second, not all lesions exhibit dysplasia will eventually become malignant. And thirdly, carcinoma can develop from lesions in which epithelial dysplasia was not diagnosed in previous biopsies. So there is therefore a substantial need to improve the histologic assessment of epithelial dysplasia, and of late interest has turned towards applying sophisticated technique of computer-assisted morphometry to investigate the cellular and nuclear changes in correlation with the histological behavior of the lesions. The results have been more reliable, objective, and reproducible. So with this background, the present study assesses the comparative morphometric analysis of normal mucosa, oral lichen planus, and oral squamous cell carcinoma. The present study compared morphometric parameters of normal mucosa, oral lichen planus, and oral squamous cell carcinoma using 13 cases from each group and image-based computerized image analysis. Significant differences were observed in nuclear and cellular area and volume, as well as in spinal cell maximum diameter, with increased values in OLP, OSCC compared with normal mucosa. These changes may reflect abnormal and rapid cellular growth associated with neoplastic transformation. Computer-aided morphometric analysis provides an objective, reliable, and reproducible method for detecting cellular and nuclear changes that may be missed by routine histopathology. Increased nuclear area and altered cytoplasmic to nuclear ratio may also help identify pre-malignant changes and also improve the sensitivity of exfoliative cytology for early detection of malignancy. However, studies with larger sample sizes, different histological grades, additional morphometric parameters, and longitudinal follow-up are needed to establish the diagnostic and predictive value of quantitative cytology in OLP. Overall, morphometric evaluation may be a useful tool for assessing the malignant potential of OLP and OSSC and for improving the early diagnosis. Thank you.
Thank you so much, ma'am. I would now request Dr. Vanna Dave, ma'am, to kindly take up the questions. Am I audible?
Yes, am I audible right now?
Yes, ma'am. Yes, ma'am.
Yeah, so I just wanted to know that how can this study be useful or utilized in a routine practice?
Ma'am, basically, in routine practice, if there are certain, if such softwares are applied to study these parameters, so this study, to study the parameters, this can actually help in early detection of cancer or any malignancy, because the results obtained with any morphometric study, they are more objective.
Okay. Okay, thank you.
Thank you, ma'am. I would now like to call our next presenter, Dr. Saida Arshia. I would request you to kindly unmute yourself and share your screen.
It just do it.
I would request Dr. Saida, ma'am, to kindly share the screen.
Yeah, I'm sharing.
Okay, ma'am.
Is my screen visible?
Yes, ma'am.
Good afternoon, one and all, respected judges and my dear fellow colleagues. I am Professor Dr. Sayyeda Shiara. I am here to present my research on unveiling gender through tooth morphometry and explainable AI approach. Accurate gender identification forms a cornerstone in forensic and anthropological investigations. Traditional approaches rely on skeletal and dental features due to their durability and resistance to postmortem changes. Among these, teeth serve as one of the most reliable indicators. Now, morphometric analysis of the tooth dimensions, particularly the mesiodistal and buccolingual measurements, have shown potential in revealing sexual dimorphism. However, conventional statistical methods often face limitations in handling complex nonlinear interactions between the variables. Recent advances in artificial intelligence and machine learning have enabled the development of predictive models that can handle multidimensional data. Now, this is the first study applying explainable AI to morphometric dental measurements, bridging research and real forensic practice. The aim of the study was to develop a random forest model for dental classification based on morphometric measurements of the teeth and evaluate its performance using standard classification metrics, enhance interpretability using features importance, permutation importance, and Sharpe values. Now, coming to the methodology, the data collection and feature extraction, it consisted of morphometric measurements of permanent canines and molars obtained from dental cast. The teeth selected were maxillary and mandibular canines, first molars, which are widely recognized for their sexual dimorphism. For each two parameters were recorded. One was mesiodistal diameter and buccolingual diameter. Each subject was represented by a feature vector comprising 8 morphometric variables, right and left canine, that is mesiodistal buccolingual, and right and left molar, that is mesiodistal and the buccolingual dimensions. No, the ground tooth label, that is gender, was determined from demographic records and encoded with the binary variable 0 as for female and 1 for male. Now, the data set comprises of 600 samples with an age of 17 to 25 years. This was the gender distribution, and right maxillary canines, total of 1200 were taken, where 600 right and 600 left. Similarly, for mandibular canines, first molar as well as the maxillary and mandibular first molars. Now, these were the final inclusion and exclusion criteria. The data pre-processing was done with all the measurements in millimeters were recorded with digital vernier caliper of 0.01 mm accuracy. However, the data cleaning involved checking for missing values, outliers, and ensuring consistency in the measurements. Now, the data pre-processing set was randomly divided into training as 70% and testing as 30% subsets using stratified sampling to maintain the class balance. Now, the model, the random forest classifier is an ensemble learning method that constructs multiple decision trees using training and outputs the mode of classification of the individual trees. Now, this was the formula utilized. And for model evaluation, the performance was evaluated using various metrics like accuracy, precision, and recall with F1 scores using all these formulas. Now, why these AI techniques were used is because random forest was chosen because it handles non-linear relationship, works well with the small moderate data sets, and high interpretability with the Sharpe values. And it also had a validation with stratified train test as 70 to 30 and measurements recorded using digital vernier caliper of 0.01 mm accuracy. Now, the feature importance analysis was quantified using the mean in decrease in impurity across the decision trees using this formula. And the model interpretability with explainable AI approach uses two approaches. One was permutation importance, which measured how shuffling each feature impacts model performance, and also the Sharpe values, which provided a unified measure of feature importance by computing the contribution of each feature to the prediction based on a particular theory. Now, this were again the formulas utilized for this calculations. The ethical approval was obtained, and the data used in the study were anonymized prior to analysis. This was the Institutional Ethics Committee approval number, and no personally identifiable information was used. And the model performance utilized the random forest classifier, which achieved a high classification accuracy of 95% for all these parameters of canine and molar with right and left measurements of mesiodistal and the buccolingual measurements. The ROC curve and precisional recall analysis showed that it demonstrated a near perfect discrimination with a value of 1, and suggesting that the classifier effectively separates males and females categories across various thresholds. And the precision recall curve further supports that achieving an average precision of 0.99. This indicates that the model maintains its high precision at varying levels of recall, reinforcing its reliability in class imbalance scenarios common in forensic data sets. The confusion matrix showed that out of 98 female cases, all were correctly classified with 100% of specificity, while 73 out of 82 males were correctly classified with 9 misclassifications. This corresponds to with male precisions of 100% and recall 89% and F1 score of 0.94%. The calibration curve also showed a good alignment between predicted probabilities and actual outcomes. The overall curve closely resembled an ideal diagonal line, confirming that the predicted probabilities are well calibrated and can be meaningfully interpreted in forensic decision-making context. The feature importance showed that analysis of canine and molar dimensions contributed substantially to gender classification. The most influential features or top predictors were left molar buccolingual, right canine buccolingual, right molar buccolingual, and right canine mesiodistal. The explainable AI or the sharp values also provided individualized interpretability by quantifying contribution to each feature. Notably, the right canine buccolingual and right canine mesiodistal exhibited strong sharp contributions, confirming their critical role in distinguishing the genders. The explainable AI, that is a permutation importance, also corroborated these findings, showing that the shuffling canine and molar dimensions significantly reduced classification accuracy, validating their predictive significance. Now, the results of the study showed that when we compared different parameters, that is mandibular canine had very high gender predictive power. Maxillary first molar also showed high, maxillary canine showed moderate, and mandibular first molar showed moderate to high interpretability. Now, coming to the discussion, these findings reaffirm the role of dental morphometrics in gender classification, supporting the previous studies that highlight the sexual dimorphism in canine and molars. By leveraging random forest classifier, we achieved superior accuracy compared to the traditional discriminant function. A key contribution to this study is integration of an explainable AI approach. Now, our results demonstrated that mandibular canines and first molars exhibit greatest dimorphism consistent with established forensic odontology literature. The high accuracy and interpretability of our model suggests that it can serve as a reliable adjunct in gender identification, particularly when skeletal remains are incomplete. Now, this is a comparison of our previous research work with our current study of advancement using explainable AI approach. Now, this was a manual. The data type used in the previous research work was manual morphometry. Current study, we used AI approach. An analysis method was statistical test, here random forest classifier with sharp and permutation importance. The interpretation with previous research work shows a limited interpretability of 80% for males and females for maxillary teeth and 78.33 in males and females. 80% in females for mandibular teeth. Percentage accuracy was 80% in males and females, and for mandibular teeth it was 78.33 in males and 80% for females. However, AI explainable feature contributed overall model accuracy to be 95%. Female classification had a specificity of 100%. Male classification recall with 89%. Only 9 males were misclassified. Outcome was sexual dimorphism proven. Here, automated classification was given with forensic applicability. The contribution for previous research was just an academic research. Here, it will be helpful for the clinical, legal, and AI tool development. Coming to the relevance of this particular research in impact on law and decision making of dental morphometrics, however, explainable AI improves reliability and accountability in medical legal reporting, quantifiable measurements. It also provides measurable tooth-based evidence, can be used in mass disaster crime investigation, and also reduces manual calculation errors and speeds up decision making, reduces subjective bias in forensic reporting. However, we had certain limitations of our research because it included only a single data set and potential variability across populations. Future work should validate the model using multi-ethnic data sets and additional morphometric or image-based features of random forest with deep learning approaches. Now, 3D dental scans and deep learning frameworks also can enhance predictive power while maintaining the interpretability. The future scope of this particular research will be helpful when we have a large and a diverse data set. Integrating this particular research with 3D imaging of cone beam computed tomography images as well as the intraoral scans that could capture additional morphometric and features, potentially increasing the accuracy. And also hybrid models can be created, which will explore deep learning approaches in combination with an explainable AI, which further enhances prediction power while maintaining the transparency. It can also help to develop user-friendly software and decision support system also, and also for it can be used for cross-disciplinary applications beyond forensics. Such models can contribute to evolutionary anthropology and dental research by uncovering certain patterns of sexual dimorphism in the tooth morphology, as well as it can be helpful in building up mobile-based forensic tooth. To conclude, this research establishes a framework for applying explainable machine learning to forensic odontology, ensuring accuracy, interpretability, as well as the reliability. These are my references. Thank you, one and all.
Thank you so much, ma'am. I would now request Dr. Vanadave ma'am to kindly take up the questions. Over to you, ma'am. I guess there is some network issue. So we'll continue with our next presentation. That is, I would like to now invite Dr. K. Pavani to present their presentation.
I'll share my screen.
Yes, ma'am, you can share your screen.
Is my screen visible?
Yes, ma'am, it is visible.
Okay. So good afternoon, everyone. So today's topic of my presentation was oil pulling, a novel treatment approach for the treatment of oral submucous fibrosis. So oral submucous fibrosis, it is a chronic insidious disease affecting any part of the oral cavity. Sometimes it may involve the pharynx also. So this oral submucous fibrosis is associated with malignant transformation potential and considered to be as a pre-malignant condition, which has a malignant transformation potential rate of about 7 to 13%. And the etiology of this oral submucous fibrosis is thought to be chewing of aracanate, chilies, nutritional deficiencies. And because of this, there will be increased collagen deposition as well as decreased degradation of collagen, finally result in fibrosis. So, and the manifestations of this oral submucous fibrosis includes reduction in mouth opening and blanching of the oral mucosa and reduced teeth flexibility and reduced tongue protrusion. However, the therapeutic approach to this oral submucous fibrosis is tailored to disease progression and the nature of clinical presentation. And the current treatment modalities include antioxidants, intralesional injections, and surgical interventions. And these intralesional corticosteroid injections has been associated with potential side effects, limiting their sustainability for prolonged therapy for this oral submucous fibrosis. So, herbal remedies and alternative therapies have gained more attention in the recent years for the management of this oral submucous fibrosis. So among these alternative therapies and the herbal remedies, oil pulling has emerged as a simple and cost-effective adjunct to treatment. So oil pulling involves swishing of the oil in the oral cavity. So this oil pulling can be done using coconut oil, sesame oil, as well as sunflower seeds. So in this study, I have used sesame oil as an adjunct modality for the treatment of this oral submucous fibrosis. So this sesame, that is Sesame indicum, which belongs to Pediliciae family, which is known for its therapeutic as well as nutritional qualities, and it consists of various bioactive lignans like sesamin, sesamolin, and sesamilin. And because of swishing of this oil within the oral cavity, so it also initiates the physiotherapy activity, which involves various orofacial musculature and finally leading to improvement of the clinical symptoms. So with this background, the aim of my study was to assess the effectiveness of oil pulling in the management of oral submucous fibrosis, and the objectives of my presentation includes to assess the effectiveness of oil pulling in improving the tongue protrusion, cheek flexibility, improving the burning sensation, as well as increasing the mouth opening. So the methodology of this study was a total of 24 participants are included in this prospective intervention study, and subjects clinically diagnosed with stage 2 oral submucous fibrosis and who are giving consent to participate in the study and who are willing to quit the habit were included into the study, and subjects with other oral lesions along with oral submucous fibrosis were excluded from the study. So in this, after informed consent obtained from the participants, they are given cold pressed sesame oil, which is obtained from the black sesame seeds, and they are instructed to take 10 ml of oil once daily in the morning on an empty stomach, and ask them to swish intraorally for 10 minutes and or until they sense of fullness in the oral cavity, and then spit the oil outside. And in this, they are also instructed to refrain from any other oral adjunctive treatment during the study period. And all the parameters that are assessed were assessed during baseline and 30-day follow-up and 60-day follow-up. And clinical parameters like mouth opening was assessed by measuring the interincisal distance between the maxillary incisor teeth and the mandibular incisor teeth. And in case of edentulous patients, from the alveolar ridge of maxilla to the mandible was measured, and tongue protrusion was assessed from the tip of the incisor to the tip of the tongue, and cheek flexibility was assessed by uh, keeping a point at the intersection of the ala tragus line as well as the outer canthus of the eye, and after that inform the patient to perform the cheek flexibility with the lips in closed position. And again we have to take one more point, that is V2, and the distance between these 2 points were assessed as cheek flexibility, and the burning sensation was assessed using the visual analog scale, asking the patient to subjectively give number according to the symptoms patient is facing. So all the parameters were subjected to statistical analysis. This is the table representing the comparison of clinical parameters at the baseline and the follow-up. And it had shown that mouth opening, cheek flexibility, and the tongue protrusion were shown statistically significant improvement. And this is the comparison of burning sensation, that is the VAS score at baseline and the follow-up, which showed statistically significant improvement. Moving on to the discussion. So this oral submucous fibrosis has been associated with chewing of areca nut and smokeless form of tobacco, betel, chilies, and nutritional deficiencies, and which causes increase of the reactive oxygen species, causing the cellular damage. And also there is, because of persistent inflammation, there is fibroblastic proliferation and increase in the fibrosis, causing your trismus, inability to open, and atrophy of the epithelium, causing the burning sensation in the patient. So for the treatment of this oral submucous fibrosis, there is no proper or definitive treatment for the treatment of this oral submucous fibrosis. And during Ayurvedic era, there are numerous Ayurvedic procedures that have been advocated for the treatment of this oral submucous fibrosis, like oil pulling, gargling, or sudation, or nasal therapy can be used as effective treatment modalities for the treatment of this oral submucous fibrosis. And this SMA oil, which is used as an oil pulling procedure, which is rich in unsaturated fatty acids, which provides antibacterial effect and also provides improvement in the oral health. And because of this anti-inflammatory and antioxidant properties which are there in the sesame oil, they will boost the antioxidant defense systems, like increase in the superoxide dismutase, catalase, glutathione, and total antioxidant capacity will be increased because of this oil pulling. And also it reduces the oxidative stress and the inflammation by lowering the thiobarbitric acid and also monoaldehyde, and also reduces the inflammatory mediators like interleukins, which helps in promoting the healing of the destructed oral mucosa. So the findings which are gained in our study, in the correct study, there is improvement in the mouth opening, tongue protrusion, improvement in the vascule, that is reduced burning sensation is seen, and also improvement in the cheek flexibility has been seen, which is in association with the other studies which are conducted by Srivatsava et al. They have conducted a study using sesame oil pulling versus placebo, and they have concluded that sesame oil pulling significantly reduces the symptoms of oral submucous fibrosis when compared to the placebo. And Sunita Gupta et al. In the year 2020, they have performed this oil pulling therapy in the treatment of this oral submucous fibrosis for a duration of 6 months, which showed significant improvement in mouth opening, tongue protrusion, burning sensation, that is your VAS score, and also gingival index. But they have seen no significant changes in the flexibility of the cheek. And another report which is given by Shikha Kaira et al., they have used this oil pulling for the treatment of oral submucous fibrosis in a pediatric patient affected with oral submucous fibrosis. In their case report, they have used that they used a combination therapy of this sesame oil pulling along with topical corticosteroid, that is topical triamcinolone acetonide, along with curcumin supplementation, and they have concluded that they have seen marked clinical improvement in the clinical manifestations of this oral submucous fibrosis. So with this, I would like to conclude by saying that this sesame oil pulling is a safe, non-invasive and well-tolerated treatment modality that can be used without any adverse effects, and it is considered as a simple, cost-effective and accessible adjunctive approach for the treatment. And also it is very helpful, particularly in improving the functional outcomes and reducing the symptom severity. And the limitations of my study was a smaller sample size was taken and a shorter follow-up duration was considered, and which limits the generalizability of these results to the patients, and also it precludes the assessment for long-term outcomes. So these are my references. Thank you.
Thank you so much, ma'am, for such an insightful presentation. Next, I would like to call Dr. Vasudha Komu for the presentation. I would request you, ma'am, to kindly unmute and share your screen. I would like to request Professor Dr. Sudipta Kar, ma'am, to kindly share the screen for the presentation.
Okay, I am sharing.
Okay, sir.
Is my screen visible?
Yes, sir, it is visible.
Okay. Am I audible?
Yes, sir, you are audible.
Oh, thank you, the organizers. Good afternoon, everybody. I am Professor Dr. Sudipta Kaur from Guru Nanak Institute of Dental Sciences. First to start with, let my privilege to thank to my all professors, and this is the arena where I work. Now, life is full of change and uncertainty. We all know this, but we experience it in our daily basis, in our day-to-day treatment protocol. Now, this is my contents. I want to share only some of my experiences regarding the subject about medical emergencies. When we study medical emergency, we found that there is two word is important. That is, it is an acute stage. Acute injury is important, and it is having an immediate risk of person's life or long time term threat to the health of a patient. So it is an important phenomena often a dental surgeon faced in their clinics. Now, I try to search what number of publications regarding pediatric medical emergencies occurs. In last 5 years, there is plenty of articles, nearly 33,000 articles I found. Last 10 years, 51, and last 25 years, we found there is 64,000 above articles found in the regarding this matter. But when we try to find out that how much pediatric medical emergencies in PubMed Index journal, we found out there is very less, and number is only 14. There is one journal in our fraternity that is called JISPPD, that is Journal of Indian Society of Pediatric and Preventive Dentistry. Only 2 articles are there. So there is some few article published in the specific medical journal here. Though in case of dentistry, how much medical emergencies, what is the prevalence, we try to find out. Here we find out that it is not very uncommon. In UK dentists, they often faced once or 2 in a year. And in Saudi Arabia, I find out there is 17.4% of that is per 1 lakh population, one pediatric dentist found these medical emergencies. Regarding demographics, I found that females are slightly more affected than the gents. So this is the clinical scenario every dental surgeon faced, but we cannot control everything. So we try to find out what are the new thing in the treatment modalities of a medical emergencies in pediatrics. Now, here in case of pediatric dentistry, we found that there is a term that is called ECC, early childhood caries. But when we consider this term in a cardiac case, they also call it ECC, and the term is here, that is emergency cardiovascular care. ECC is also applicable here. What is the meaning of Facebook? FB is Facebook, but in case of dentistry, FB means foreign body. When a child ingests a foreign body, it is often considered as a medical emergency also. So what's new thing in antibiotic prophylaxis in dental patients with having the risk of infections? In a cardiac case, I found in recent literature, they kept out clindamycin from their regime, as because clindamycin causes severe diarrhea to a child patient. So American Heart Association recently kept the clindamycin off from their regime. Now, the next thing, what is American Heart Association's guideline in recent years, that is 20-25 years? There is a change. Previously, we'll follow that there is a protocol, we call it PABCD, that is positioning of the patient, airway management, breathing assessment, circulation, you have to check, and definitive care. But the recent guideline has changed. They uttered CAB sequences. Now, what is this? They make it shorter. CAB is C for chest compression, A for airway management, and B for breathing assessment. This only three things is required to resuscitate a patient. This is the modern guideline. So why there is need for replacement of CAB, though it was previously PABCD or ABC? Because in American Heart Association's guideline, C comes fast. C is for chest compression, is one of the most important thing now we are considering to rescue a child or adult patient. Now, another recommendation. Previously, we thought that in a patient having replacement of prosthetic joint replacement must need and a dental and antibiotic prophylaxis during dental treatment. But today, these are the era of evidence-based dentistry. This evidence-based dentistry said that there is no need of such antibiotic prophylaxis during dental treatment of a patient having prosthetic joint replacement. This is another thing. Now, another very unusual thing, often we are trained in the BLS procedure that there is a instrument that is called AED, that is automated external defibrillator. In every BLS training procedure, the experts always try to give emphasis on this. But I try to find out what is the cost of this instrument. You will be astonished to see that the cost of the instrument will start from nearly 50,000 to 1,12,000. So it is nearly impossible for a dental surgeon who is trying to practice initially to keep this instrument in their dental chamber to combat any kind of emergencies. Now, second thing is adrenaline injection. In the literature, they have given that there is ready-made adrenaline injection is available in the market. That is 0.3 milligram adrenaline injection. That is for anaphylaxis, which is another medical emergencies. Now, I try to find out what is the cost of this. I am not getting this. The cost of this material is nearly 6,000 to 20,000 per syringe. So it is again very costly for a dental practitioner to keep it in their clinic to combat the emergencies. But what to do? When emergency came, you have to combat with these emergencies. Now, I have a formula of having similar drug with very less cost. Well, that is cost-effective methods you can apply. Here I am giving, if you secure a adrenaline injection, simple ampoule, it only costs 15 rupees. And another, you can keep hydrocortisone, you can keep dexamethasone, derifylin, aspirin, or any kind of antihistaminics, glucose, then midazolam. If you keep these kinds of simple medicines, the total cost will be only 752 rupees. And with the help of this simple investment, you can try to avoid medical emergencies in their dental clinic if possible. This picture shows that we are fortunately enough, because when there is emergency situation, it is very difficult to give any kind of injection in IV format. But most of the injections, emergency injections, you may give IM. That actually gives a good vibe for our professions. Now, there are another some changes also occur in pediatric basic life support. Previously, we use two-finger method for pediatric basic life support. But now the terminology has changed and the procedures is also changed. We give 5 back blows and 5 abdominal thrust to give a child as a pediatric life support. Now I try to highlight some another thing, that is everyone in their dental clinic may face dental trauma, the child or adult having dental trauma, traumatic dental injury. So often there is need of splinting. So there is a protocol, and the protocol is very much difficult to remember. So there is one simple formula. You can just remember C. C means subluxation, S, E for extrusion, and A for avulsion. For C, you have to splint 2 weeks. In all cases, rather than C, 4 weeks splinting is needed. And there is only one exception in case of permanent root fracture. 4 months splinting is needed. This is for all practitioners. When we practice, it is very difficult to remember that how much time I have to give for a splinting procedure. So you all know this. I just try to recapitulate as my own manner. There are some emergency code. You can find out some emergency number is there given by the government. That is in case of ambulance 108, in case of emergency 112. These are the emergency codes. So when we try to combat an emergency, it is always a team effort. You need support. So you have to utter for the assistance, quick assistance from other people. So during treatment, you have to rely on only 3 things. That is 3 C's. That is, when you are in an emergency, please stay calm, be caring, and be curious. So 3 C's are our campaign, but as our conference is having 2 D's, I must say that 2D is important, that is discipline and determination. This 2D is always keep ourselves away from others, keep ourselves more advanced from others. So these are my references, and life is full of uncertainties, but there will always be sunshine after every sunset. Thank you very much. Thanks for patient hearing.
Thank you so much, sir. I would request Dr. Punita Vora ma'am to kindly take up any question or engage with sir in some brief discussion for the topic.
A very good afternoon to everyone. So Dr. Sudipta, your presentation was really very insightful. I think it was very well presented. You have almost covered everything regarding the medical emergencies and how to manage it. So just a simple question. What is the most common emergency which you can encounter with the pediatric patient? on a dental chair, and the commonest drug which can be given to that patient to, manage that case.
Yes, ma'am. Actually, in pediatric dental cases, foreign body injection is one of the basic problems.
Yes.
So, helming maneuver one has to practice in their clinical practice so that foreign body can be removed easily. Another thing is syncope, but syncope is not usually occurred in a child patient as because the child are having the naughtiness. So when the child is having syncope in the clinic, you should always take care on an emergency basis because one should have very little bit of time to combat this because there is very quick chance of shock. A patient may transfer into shock very quickly from syncope. So it has to be combat immediately. I think these two things one should avoid in their clinic.
Very nicely said. So thank you so much.
Thank you very much, ma'am.
Yeah. Dr. Yashi, ma'am,
Thank
you can carry on with the next presenter.
Thank you, ma'am. Thank you, sir. I would now like to invite Dr. Hemil Shah, sir, for the lecture, who is a renowned dental professional and the founder of Ostriji Dental Clinic and Implant Center, Ahmedabad, where he has been practicing since 2000. He is a graduate of Government Dental College and Hospital, Ahmedabad, who specializes in microscopic dentistry, advanced endodontics, dental implants, laser dentistry, dental surgery, and cosmetic dentistry. With over a decade of experience in education, he founded the Academy of Advanced Endodontic Education, that is AAEE, in 2010, where he conducts advanced workshops and training programs for dental professionals. He is a fellow master and diplomate of the International Congress of Oral Implantology, USA, and is associated with several leading dental organizations also. His philosophy is treat human beings and not patients, which reflects his patient-centered approach to dentistry. I would now like to invite Dr. Himasha sir for the lecture. Over to you, sir.
Thank you so much, Doctor, for the introductions, and thank you, IDDCON, for the opportunity. So let's start with the presentation. So every treatment starts with the utmost care, gentle touch, and hand holding. So this picture showing that we have to take care of each and every patient that comes to us. So good evening, everyone. Let's start the journey of my presentations. So over the past 2 decades, 2.5 decades, I have evolved myself with the magnifications, microscopic dentistry with surgical endodontics, and multidisciplinary treatment planning. So here I'm not sharing about my credentials, but my job is to tell you that one situations that even a senior practitioner, even the experienced practitioner has to test their skills. They have to think twice whether we should perform or not. And the thing is endodontic retreatment. Today's topic is endodontic retreatment excellence, turning failures into the success stories. So the introduction is given by doctor. Now, 2010, since 2010, I am working with dental operating microscope. So what we cannot see, we cannot treat. So that's the famous word from Dr. Key. So my point is here is that even when we think about retreatment, you should understand that what we have to face, what we are going to treat, what that previous dentist has left, and is that tooth is savable, or is this tooth has a good prognosis? Because endodontic retreatment is just not taking gutta parcha out and filling it again. We have to evaluate the things. One, is there any broken instrument, ledge creation, perforations? Is the tooth is really restorable or not? If we think about all these criteria and then we try to perform the retreatment protocols, will definitely save the tooth. So let's start the journey. So you can see this teeth. This is perfectly obturated. Everything is taken care. Still, this is very well accepted RCT, but still biological unsuccessful. You can see the very big cystic lesions from mesial distal root and the distal part of the premolars. Now, what happens? There is a persistent infections, apical inflammations that is there before RCT. Now, if you treat it well, but still after inadequate RCT, you can see residual microorganisms, persistent intraradicular infection, and persistent apical periodontitis. Now, all these things we have to consider, and then we need to think about the retreatment. So what are the main factors for failure of endodontic treatment? First of all, inadequate cleaning and shaping, complications like ledge, perforations, separated instrument, iatrogenic procedures such as poor access cavity design. So most of the things, when I encountered a separated instrument, most of the things I found the poor access cavity design. Untreated canals, both major and accessories, improper coronal seal, and over and under extension of root canal fillings. These are the major factors when you find when you have a case with the retreatment. So what are the main reasons after RCT? Why disease persists? So infection never eliminated, inadequate irrigation. So study shows that if you are not properly irrigated with the sodium hypochlorite, and if you are well irrigated with the sodium hypochlorite, the chances of bacterial load is decreased by 99.78 and the endotoxins are reduced by 59.99. So my point here is we should understand if you find persistent infections after root canal, the main point is irrigation. Now you can see this picture again. Dr. Kim and Kretschmann did the study. So if you fill your canal 3 mm short, then apical periodontitis and lateral canals are left by 98 and 93%. If you left 2 mm and 1 mm, you can understand the majority of the lateral canals ramifications lies in last 3 millimeters. So one has to understand that if you are not able to clean this area properly, then you have a more chance of failure of root canal. So majority of the cases, really you find that the improper biomechanical preparations and improper irrigations are the main cause for the failed root canal. The most important part in India, if you can understand the importance of isolation, majority of the people are not applying the rubber dam. They are even not properly irrigated, properly isolated when they are doing obturations. I have seen in some other clinics that they are just, their teeth is fully filled with saliva and they are doing obturations. Sometimes single person is doing all the treatments and they are not taking care of isolation. Now, if you are using good sealer also, but still you can find the bacterial leakage. So important is in any re-RCT cases, the most important bacteria you find is E. fecalis. So E. fecalis find 19% in saliva and root canals is 38%. So most of the cases, when you take the history, they said, patient says that I had done the root canal before 6 years, 7 years. And then suddenly it started failing because of this bacteria, that this bacteria can remain dormant in root canal systems for 7 to 8 years. Now, if you take care of isolation properly during your obturations, you can reduce your rate by 9.7%. And if you are not taking care of the isolations, there is always increase a chance of 9.7%, while E. fecalis you find in the root canal system. So main point is short obturation is also responsible for the more bacteria in the root canal system. So here I want to make a note that if you are taking care of isolations, your failed root canal chances are decreased at least by 30 to 35%. Now, another study show that human saliva coronal microleakage in obturated root canal. So if you see that they have studied 150 teeth over a period of 2, 7, and 90 days. Salivary penetration increased with time, and the 3 months, the penetrations was considered clinically significant. So now my advice is that any root canal started, it has to be finished within the 30-day time frame. Because now we all know that we have approach for single visit RCT, but sometimes if you have a drainage from the system, weeping canal, you cannot finish that particular root canal in a single visit. So if you are able to manage the root canal filling within 30 days, you have a more success chances of your root canal done. Sometimes what happens, clinician make mistake that whether it is an endoperio case or a perioendo case. So we have to be very careful about selecting the re-RCT cases. Now the most important part in tobacco chewers in some deep bite cases where patients develops crack. So if you do the root canal treatment in the cracked tooth syndrome, what happens after 3, 4 years or 5 years, patient comes with the swelling and then you find a separated root in the IOPA or a radiogram. So we have to be very careful about cracked tooth syndrome while we are performing a re-RCT case or even the fresh RCT cases. Now you can see in this picture that whole the pulp tissue is out. Now you think that if you are taking this and your BMP is done, no, not at all. You have to thoroughly irrigate the systems, because if you are not able to eliminate all the toxins, debris, and bacteria from the canals, you are not able to control the infection. Now, let's understand untreated anatomy, missed anatomy. Now, I will show some my pictures that in this case, you can find MB1, MB2, and MB3. Here you can find MB1 and MB2. So, under magnifications, you can find MB2 in 99% case. Even with the upper 7, you can find 50% of the cases you can find the MB2. And if you encountered failed RCT, the majority of the cases in upper molars are the missed MB2 and sometimes MB3 also. Now, here in this case, you find 6 canals in lower molar where you find mesiolingual, middle mesial, mesiobuccal, distobuccal, distal mesial, and distolingual. So if you miss this canal, then you'll definitely ended with the failed RCT. Now, this is a challenging things when you encounter a C-shaped, it has a different type of protocols to need this type of canal, irrigations and the motions which we require to clean this canal. If any tissue left in this C-shaped canal, it is going to reoccur the infections and then we have to retreat it again. Now, if you find this as a broken tooth, but patient want to save this tooth, now you can find that I found that there is some problem with the obturations, and then I thoroughly irrigated it, and then you can find the lateral canal filled. So as soon as I fill this, the symptoms are started disappearing, and within a week or 10 days, we can see the healing. Now you can see missed MB canal. Now this is a perforation case. So this is managed by this is the perforation sealed. Here patient comes with a severe pain and there's the missed DB canal you can easily find here, and it is done and all symptoms are gone. Now you can see the broken instrument here, file retrieved and canals negotiation done and obturation done. Now this is the case. There's a very interesting case where you find a broken instrument in MB2 canals. You can see curvature of the root of MB. Now after file removal, and then you can find this, we can reach up to the apex. So this patient is I had treated in 2010, and the last year she came and changed her crown. So teeth is still functioning in the oral cavity. Now you can see that patient is referred to me for this mishap, and then everything is fine. It's a lower central incisor and file is retrieved and obturation is done. So we are here to save the tooth, not to extract. Here you can see there is a patient from USA. He wants that I don't want to extract my tooth. I have a pain. He had crown done in USA and it's a third molar. And you can see that there are 2 canals filled. And after removing all the old filling and under magnifications, I was able to find 4 canals and obturated. So here you can see radix entomolaris. Why I am putting this slide? Because in India there is a prevalence of radix entomolaris. So if you miss this kind of anatomy, you are really going to end up with the failure of your root canal treatment. So we have to be think, and we have to take X-rays on a different angle while if we are doing RCTs. Now you can see the third molar. So here it's again patient doesn't want to extract the tooth. You can see the lateral canal fields. Another one, completely crown is given, no obturation is done, hardly some obturating material you are seeing here. And then after doing proper biomechanical preparations, we can reach up to the apex and tooth is still in the mouth. Now again, a re-RCT cases that you can see clearly a missed canal infection under the crown. I have retreated it and perfectly So curved canals and lateral canals. So whenever you find infections in the lateral aspect of the root, you should consider that the portal of exit is not at the apex, but at the some lateral side. Now you can see the curvatures. So actually, whenever you are trying to perform a RCT or re-RCT, you need to understand in this digital era, you are supposed to thoroughly examine the case. If you are in doubt, go for micro-CT. We have in so many clinics right now, we have a CBCT. Use magnifications, use lots of irrigations, use ultrasonics, and by all that means you can achieve this kind of results. So now my point is that the root canal is not a single tube. It has a main canal, isthmus, lateral canal, apical delta, accessory canal, fin and anastomosis. So what in previous side, whatever you have seen, the obturations, it is done with the downpack and backfill machines. So we have a B-fill, we have available calamus, we have so many systems available in the market. From that, you can achieve this kind of results. So it is not only the clinician ability, you have to invest in a good machineries and equipments so that you can achieve good result with the re-RCT cases. Now you can see this. So in my opinion, single canal is a rare entity. So if you understand that if you have started RCT and you reach up to the apex and in your apex locator 00 reading is there and you are happy, okay, I have reached up to the apex. So it is just a rare entity. You can find anastomosis, lateral canals, so many things you find in your root canal systems. And our purpose is to clean all the canals with the proper irrigation protocols, not with the files. Now you can see the short obturation and you can see the very big periapical region. So in these studies, if you do the obturation 1 mm loss by your working length, there is an increased chances of your treatment failure by 14%. So if you understand that if you are doing mistakes and your obturations is very short, so over a period of time, within 3-4 years, then canals are going to leak and then you have a periapical infections. So it is mandatory to fill up to the apex, and we have to evaluate after obturation. By every case you have to take the IOPS. So what happens actually? What is the blockage? Sometimes if you are inserting first file and your canal is blocked, so within the first instrument you are creating a ledge. Sometimes you push your tissue to the apex, right? So that is creating a apical blockage. Then no file can reach up to the working length and you are ended it with the inadequate working length. Ledging, the most common thing as I introduced. So mostly you have to use a crown down technique and then you have to insert your first 10 number K file. You have to pre-code it and then you can reach up to the apex. So you have to clear the ledge and then you have to maintain the working length and glide path. And if you are maintaining all these things, you can clear the ledge and reach up to the apex. Because majority of the in re-RCT cases, dentist has created ledge. In my practice, I can see even 70 to 80% of cases, there is a ledge formation and we have to clear it. Now you can see the ledge and ledge is cleared. So Now, if you are reaching up to the apex, so that's not only the criteria. Whenever you perform a root canal or a re-RCT, it is mostly the disinfecting the canal. So if you are taking out the GP, you are removing the blockage, you reach up to the apex. But first, we need to understand why we are doing re-RCT, because there is pain. If there is pain, there are so many possibilities. If the percussion involvement is there, root fracture is there, okay, then there's not the case where we should save the tooth. But yes, there is a infection, patient has a severe pain after RCT, then the main objective is to remove the infection from the canal, and that where comes the irrigation protocols. So what happens? Poor obturations may reflect persistent infection, inability to dry the canal, and poor apical seals. So this is all about a vicious circle. If you are not able to do BMP proper, then you are not able to obturate proper, and then again you have a poor apical seal, and again the infection occurs again. So what are the chances if you are doing a proper retreatment? What is the prognosis? So prognosis is very good. Now, what we have to understand, why patient comes to us? They are not able to chew, swelling is there, tenderness is there, sensitivity to pressure or temperature, darkening of treated tooth. So what are the steps? First, thorough clinical examination, clinical testing, and radiographic analysis. If you are not sure with the 2D radiograph, you should go for the CBCT. So sometimes focus is not just selecting the right thing, but also saying no to the wrong thing. Means sometimes we have to say no to the patient that this teeth is not at all savable, so that we are going to extract. Now you can see this teeth, all of full discoloration of the tooth. Tooth is broken down. And if you remove this brownish part, then there is no tooth structure left. So now we are not supposed to save this teeth. Sorry for this X-ray, but you can see the root are separated and then it has to be extracted. Now you can see there is some minor percussion involvement in the molar, but patient comes with the complaint in premolar. Patient doesn't have any pain. Now you can see the distal root where there is a short obturation, but still there is no periapical. Now you can understand the nature. Now you have a premolar with the severe periapical infection, and with the molar with the percussion, you can see the density of the bone is not good there. You can see the crown is leaky, but still there is no periapical infection. So you can understand sometimes nature helps us to cure. So, and we have to just rely on our technical things, our protocols, and the things which we are learning every day. Now, do you think that we should save this tooth? No, because in this case, there is a big periapical lesion and we should go for an extraction. So in this case, I extracted the tooth, I removed the cyst, and then it is filled with the bone grafting. And then we have to wait for 6 to 9 months, and then we can go for the implant placement. So what are the scope of retreatment? So in Indian population study, you can understand 37.4% of root filled teeth had a periradicular radiolution. So in that one recent study in Mumbai, that said that 67.6 of failed teeth were molar, making posterior complex retreatment particularly relevant. missed canal are strongly associated with post-treatment diseases. So 85.1% of root filled with the missed canal versus 56.3 without a missed canal. So now you can understand, if you are treating your case also, and if you are a senior practitioner, if you have 10 years of practice or 15 years, your own case will going to come with you and you have to treat it with it. Now, the most common retreatment is molars, where you find 67.6% failures in Indian populations. Now, we have to be very careful about this, that in other countries, these ratios are less than our countries. So, the scope of retreatment, 25 to 40%. Now you can understand that if you are doing root canal today, and if you are not taking care of certain criteria, and if you are taking care of all the criteria, but still there is a scope of 25 to 40% of retreatment cases. Now I'm showing one interesting study that if you do a very good endodontic treatment and good coronal restorations, your success ratio will be 91. But still, second, you can see that if you have a poor coronal restorations, your success ratio is reduced very drastically up to 4.1%. Now, another interesting thing that, okay, your root canal is not up to the mark, but your coronal restoration is good, then you have a very good success ratio of 67.7%. So in all the criteria, if you understand that good coronal restorations play a major role in the treatment success. So what we have to do that in retreatment cases, there is a success ratio of 45 to 90% if the all criteria are met. If you consider that 85% of success ratio happens after 10 years, so if you are very taking care of your cases, re-RCT cases in a good manner, then you can save patient teeth for at least 5 to 10 years. So what are the main challenging things? 80% of the failures are asymptomatic. So in my opinion, if you can able to manage recall visits, follow-up visits for your re-RCT cases, you can find what is happening after your root canal treatment. Sometimes what happen, you can find leaky margins. You can accept your failure also. If you have done your crown and you find leaky margin, just remove the crown, remove the secondary caries, and give a new crown, so that again your root canal treated teeth can be in the patient mouth in more than 5 to 10 years. Applied fluoride margins. Tell the patient that they do proper brushing and flossing techniques near the crown. Now you can see the heart is filled near the middle 1/3. So every time you work, you create a beauty every time. So now my take-home message for this. So failed RCT is not always a failed tooth. Diagnose before you retreat. Identify the true cause of failures. Respect the anatomy. Try to use magnification, illumination, CBCT, and meticulous technique can reveal what was previously missed. Our goal should be preserve the natural tooth whenever predictably possible. Save the tooth, not just the treatment. Failed RCT, correct diagnosis, predictable retreatment, and natural tooth is preserved. So my last sentence is for this take-home messages. When tooth is restorable in retreatment cases, first choice is to save the tooth and not to place the implant, right? So I would like to end with the one quote that every re-RCT cases has the story. Our job is not to treat the teeth, but one has to understand the story of the patient and the tooth, and we have to take care of that particular patients, those who comes for the RCT cases. This is my details. If you want to know more about it, you can scan the things. So this is from my side. Thank you so much.
Thank you so much, Dr. Hemant Shah, sir, for such an insightful and enriching lecture. Your expertise and valuable perspectives have certainly added to our learning experience. We truly appreciate your time and contribution to the International Digital Dentistry Congress 2026. Thank you, sir.
Thank you so much. So if you have any questions, you can ask. I think all doubts are clear.
If there are no doubts, then we can carry on with the next lecture.
Sure, sure. Thank you so much, Doctor.
Thank you, sir.
Thank you.
I would like to invite Dr. Punita Vora, ma'am. Dr. Punita Vora is an MDS and professor and head of the Department of Oral Medicine and Radiology at SGT University Dental College, Hospital and Research Institute, Gurugram, Haryana. With over 16 years of experience in clinical practice, teaching and research and academic leadership, she has made significant contributions to oral medicine and maxillofacial radiology. Her expertise includes oral potentially malignant disorders, oral cancer, oral mucosal diseases, advanced oral imaging, salivary gland disorders, temporomandibular disorders, and tobacco cessation. She has also organized and chaired continuing dental education CDE programs, workshops, and interdisciplinary academic initiatives aimed at promoting evidence-based clinical practice. A dedicated academician and a researcher, she has published extensively, contributed to academic books, mentored undergraduates and postgraduate students, and continues to promote excellence in dental education and evidence-based patient care. I would now like to invite Dr. Punita Vora, ma'am. Kindly unmute and share her screen. Over to you, ma'am.
Thank you so much, Dr. Yashna. I hope my screen is visible.
Yes, ma'am.
Okay. So today we'll be talking about technology, a technology which is changing everything in dentistry from top to bottom. Let me switch on my camera also. Is my screen visible and am I audible, Yashna?
Yes, ma'am.
Yeah. First of all, thank you, Dr. Noodle and the team for giving me this opportunity. So this topic, technology as such, is very close to my heart because we deal on a daily basis with the emerging trends which are changing in oral radiology and how we are diagnosing the cases. 10 years back, a decade back, we only used to rely mostly on panoramic radiographs, and now how drastically the things have changed. I think there is hardly a clinician in the market who is not using CBCT to diagnose, even if the simplest of the cases, to avoid any complications to their patient. So I am Dr. Punita Vora. I'm heading the Department of Oral Medicine and Radiology at Faculty of Dental Sciences, SGT University and Gurugram. So let me just take you through the journey of not only radiology as such, dentistry in whole, because radiology is just an arm which is used to diagnose the cases in dentistry. And I'll always also will be covering a gap which is there between the oral radiology and general radiology, how that gap is also getting covered day by day and with the changing times and era. So first of all, whenever we hear the word AI, certainly in some minds, there is a doubt that is this going to replace my job? So AI and advancements in radiology are not here to replace the radiologist. They are here to empower them. So I strongly believe in this. So on daily basis, we are trying to use AI and integrate it into our diagnosis. And it is, believe me and trust me, it is just going to help us down the lane. It will allow us not to miss even the discrete details which might be missing through a human error. So it is just going to empower us. It is never going to replace us. AI will always need a human in loop. AI can never work without the human emotions and human brain. So it is just going to empower us. So the era of modern dentistry. So this is where we started on a dental chair. You can see what kind of dental chair it was some 50 years ago. And this is where we have reached with high-speed rotors and digital dentistry and digital scans. So the most significant advancement in dentistry, I believe, has been a high-speed handpiece and a cone beam CBCT. The cone beam CBCT, I'll not be getting into details of basics of CBCT because I'll be talking more on advancements today. But still, I believe there are a lot of people who are not aware of what actually a CBCT can do, where all it can be used other than just putting implants. So a brief overview I'm going to give you. And the digital physical bridge, how the digital physical bridge is converting a volumetric data which we attain by CBCT into putting a device on our table for treatment planning, not only planning of the patient, but actually doing the treatment using that scan and then converting into a 3D dimensional digital 3D printing, a blueprint, which can decrease the anxiety of the patient, which can decrease the anxiety of the surgeon also and a dentist also, and how it can completely change the treatment planning, how it can become a conservative treatment plan without harming the patient. So this I'll talk in the end. CBCT, what, who, why, and when. 4 W's, which you must remember that when and why you need a CBCT scan. It is not something, you check a patient and always you have to write a CBCT scan. It is not like that. So the basics should be clear to you, then only we can head on to the advancements. So what is CBCT? It is a cone beam. So the term itself explains we are going to use a cone beam to take a 3D view of a patient, and that's how the images are constructed. We take a scout image and ultimately the complete 3D views in all the planes, axial, coronal, and sagittal views are attained. And finally, a secondary reconstruction for a 3D reconstruction view is also attained for the education of the patient. So why we use it? We use it because the panoramic imaging, definitely, it is a 2D imaging. So there is magnification, there are distortions, there are anatomical superimposition. And the CBCT, though it is going to be a 3D view, we can see the complete geometric image of the patient. We can take the image which is totally undistorted and an accurate dimensional view is attained. So who relies on it? All the modern clinicians who are running a modern practice and they want a precision in their dentistry. They all are using it, and when to prescribe it depends on what kind of patient you're dealing with, from orthodontic to trauma to airway to implantology to endodontics. Everywhere it can be used, and I'll show you the pictures how it can be used. So this is what a 2D and a 3D image look like. It's like a completely different view. When you see a 2D view, you can think of something else, and when you see a 3D picture, you come to a totally different diagnosis. So this picture tells the story of 2D and 3D, how different it is when you see a 3D picture and how different it is when you see a 2D view. So a CBCT, as I already mentioned, it is from 2D to 3D imaging. So just a small video to show how the scan takes place. So this is, it is just going to show you that how the scan gets into you, how the field of view changes. With time, you will see a cone beam is coming. This is a small cone beam. So this is a small field of view. Slowly the FOV will increase. So the machine has two things, hardware and software. So nowadays the hardwares are being changed. Even the softwares are so developed. We can see the complete skull. So that is how we have bridged the gap between the dentistry and the medical. So we can see the complete orofacial region. Rather than just seeing the jaws, we can see the complete skull. So there are different machines, different companies who are manufacturing on daily basis. Even AI integration has come into the play already with the softwares which are being developed by the latest machines. So voxels and pixels, this I'm not going to teach you in detail because it is a completely different topic, that how the image construction takes place and everything. So, but basically I'm going to differentiate between the medical imaging and the dental imaging. That many people have a question, why don't I go for a CT scan? If there is a trauma case, it's okay if I take a CT scan. If there is a patient in which I have to get the implants done and see the bone and see the health of the patient, why not take a CT scan? So with the CT scan, there are 2-3 big problems. One big problem is that with CBCT, we receive isotropic voxels. You can see in the image that these voxels, these 3D picture elements, like pixels are for 2D and 3D picture elements are known as voxels. These voxels are isotropic in case of CBCT. But in CT scan, as you can see in the medical CT scan, these are not of equal size. They are anisotropic. Hence, the various softwares which are being developed to do the implant planning, to do the simulation of the implants, to cut the paraxial sections, all these things, all these makeovers, smile designing, doing the 3D printing precisely are not possible with the help of medical CT. So the field of views, as I showed you in the video, so this is the field of view, or you can say the region of interest. We don't have to expose the complete skull of the patient with the cone beam. We can decide that we want to see this much image. So accordingly, we tell the patient that fine, we'll take this much view. So the field of views can differ. They can be 5x5, just a small medium field of view, 10x10. Even we can take a single tooth scan. So when you are putting the this thing on the patient, referral to the patient to a radiology department, please mention that how much area you want. Please mention you want 2 teeth to be seen, you want full orofacial scan, you want a full FOV, or you want a small FOV. So I'm not going to compare this because we all know the drama behind the 2D and 3D. So the CBCT and CT, as I told you about the voxels, one thing which is good about CBCT, which is good about CT scan, is that the soft tissue imaging is very precise in a CT scan. So when we deal with the patients of cleft or with the patients who have multiple fractures, so in those cases, might be that an oral surgeon would prefer a CT scan rather than a CBCT. But again, the problem lies with the fan beam geometry of the medical CT scan and the cone beam CT, which gives a cone shaped beam. So with the cone shaped beam, the scan time is hardly 10 to 18 seconds. With the medical CT, the time of exposure is around 10 to 15 to 20 minutes minimum. And the amount of time is directly proportional to the amount of exposure you are giving to the patient. With CBCT, the exposure is hardly 68 microsieverts and 100 times more. You can see the medical CT, the exposure is 3300 microsieverts. So you have to follow the principle of as low as diagnostically achievable. You have to give less amount of radiation to the patient. Please don't harm your patient. Go for CBCT if with the less exposure, your diagnosis can be done. So this is the comparison between all three. So this is the images which we attained. Now, basically, these are the scans: axial scan, coronal scan, sagittal scan, panoramic view. All these views can be attained on a single CBCT scan. These are the para-axial sections. Now this you cannot attain in a medical CT scan. Now you can further cut the axial scan into multiple sections, cross sections, and then you can see what is the width and height of the bone. This you cannot do on a medical CT scan. On basis of this, that 6.57 mm is the width and 6.12 mm is the height of the bone, you can place an implant without any second thoughts that I need a implant with 4 by approximately 6. A mini implant will do with this patient. So these are the paraxial sections. So clinical application, maxillofacial surgery, not only implant placement, impacted tooth, trauma, cyst, any pathology, cancer detection. Then localization of an impacted tooth. Localization on a 2D view is very difficult. Whether the tooth is placed palatally or it is placed labially, you can easily see it on a CBCT scan. And you can also see what effect it is doing on the surrounding structure. So when you're pulling the tooth out, extracting it out, you can directly see in this on the slide number 1, 2, as well as wherever I have placed an arrow, that it is almost touching the nasal floor. So you have to be careful with the extraction part there. So these are the axial cross sections. And with the coronal, all of them, and this is the 3D reconstruction view. This is not used for diagnosis. This is just to explain your patient that your tooth is lying here, which you cannot do on a panoramic view. There are beautiful softwares. They can also put a soft tissue on the face of the patient, and then that's how you can educate your patient. More than educating, you can communicate very well and nicely to your patient using this technology, which is there in the latest softwares, that how your tooth is placed and how we are going to extract it. That decreases the anxiety of the patient. So the nerve canal, this is the tracing of the nerve canal. Nerve is a soft tissue, but definitely we can trace the mandibular canal, IANC, very easily. And we can see the approximation of the root of 8 or any other tooth, that how close in the mandible the tooth is lying to the nerve canal. So that we don't cause any injury to the nerve canal. Then trauma detection. On this scan, you can hardly detect a trauma, but here you see that there is a trauma on the symphysis region of the patient. So you can miss out on trauma on a OPG, though it is very precisely shown that how on the paraxial view also, you can easily see that even the inferior border of the mandible is fractured. There is a lingual fracture. Lingual fractures are very difficult to diagnose using a OPG. And some people try to use an IOPA to do that. And I don't know which eyes they have to diagnose it through a IOPA. So this is again a trauma assessment. Easily we can see a subcondylar fracture. It is displaced. We can see it on a coronal view. We can tell the patient on a 3D reconstruction view. The cyst and tumor. So you can see a dentigerous cyst. You can see the extent, precise extent. Now it is 19.5 mm and 12.78 mm mediolaterally, the amount of expansion it has done, what it has done to the lingual cortical plate. All these things cannot be done on a 2D view. So in endodontics, as in previous lecture, sir was telling what are the complications, why re-RCTs are required. So one thing which is very important, please diagnose your case properly. You will avoid complications. You will avoid re-RCTs. Now, there are hidden canals, there are lateral canals which can be missed, and CBCT is the best way to detect a hidden canal, a C-shaped canal, or to identify any root fracture or tooth fracture which cannot be seen on a IOPA. So on this IOPA, everything looks normal, but when we take a scan and then we analyze that, yes, there on the mesial root, there is a periapical pathology and there is a post-endo CBCT done for this patient. Now, after doing the re-root canal, because the pathology was there, so the patient, the pathology has healed. So if there are any root fractures, see on a IOPA, you cannot see anything. You can just see the dental alveolar fracture, but actually you can see what it has done to the root of the tooth. So implantology. So this is the fracture implantology. Now, if we place an implant just by taking OPG into consideration, this is what happens. Just a second. This is what happens. See how your tooth has, you were very happy to see the OPG that you have done a very successful implant surgery. So this is what you have done. The implant has been placed totally. It is not inside the cortical plates. So this is an implant failure case. Again, your implant, you on cropped OPG, you can see that it looks very beautifully done. There is no issue, but yes, the patient will come after 2-3 days to you. There is a big issue. You have not placed the implant inside the alveolar bone. You have placed it very, very labily. It is not inside the bone. It is not going to osseointegrate. It is going to come out in the hands of the patient. So similarly, many patients are there in which there is implant failure just by using the OPG. Please never do an implant case. So with the help of CBCT, you can measure the width of the bone. You can measure the long axis. You can see the landmark localization can be done. All the vital landmark localization can be done using the CBCT so that you don't harm the patient. So these are the various para-axial views, as I was telling you, where you can do the implant simulation. You can measure, you can put the implant 2 mm below the alveolar crest. All these measurements are not possible on an IUP or a RBG. Then with the help of CBCT, you can easily do the implant verification. You can check what is the density of the bone where you are planning to put an implant. Then this is what a virtual implant placement looks like. There are implant libraries in the software of CBCT machine, in various softwares, Romex's software. Every machine has a different software, just like your phones. So like your Apple has iOS, your Samsung has Android. So based on this, there are different softwares with the different machine, and every software works differently. But implant simulation is the mostly there with good machines and softwares. You can place the implant and you can show it to the patient and you can easily feel comfortable. And now further, when I go into advances, you will see that using this implant simulation, we can further do a 3D printing. We can create a surgical guide, and then using that guide, we can, without doing any harm to the patient, any trauma, we can easily use that surgical guide and we can place the implant without causing any pain to the patient. Post-implant assessment, it is very easily done using a CBCT. Now advances. That was just the basics of CBCT. This was what has been done in last 10 years. Now I'm going to move to the transition which is taking place and how we are going to ahead in next 5 to 10 years. Now the digital mandible, oral radiology, and additive manufacturing. From CBCT, we have moved to a 3D digital workflow. That means everything, a 3D printing can be done. And using that 3D printing, you take a CBCT scan, you get the image in DICOM. Okay, that DICOM image can be put into a different software. There are different softwares to plan 3D printing. All you need is a STL conversion file in your CBCT scan. That file is taken, and with the help of softwares, the various softwares, there are endoplans, the different names of softwares. Those softwares can plan a printing. Then a 3D print is available to you after 3D printing has been done. And using that 3D printing, you can treat your patient without causing any harm to the patient. So this is the guided implant placement. Suppose you have to place all in 4 or all in 6. Complete denture has to be given using the implants. So this is the best way. Rather than creating a mess with the patient, you can take the CBCT scan, use the STL file, do the 3D printing, and then using those guides, using that 3D print which you have achieved, this is the 3D print which you have achieved, you can directly place the implant by doing a minor surgical procedure in a single sitting, and you can give the complete denture to the patient in just 1 or 2 sittings to the patient without harming the patient, without causing any trauma to the patient. Because they all are elderly patients, they all are immunocompromised, they all have diabetes, hypertension, so many lifestyle disorders. So you just cannot go on playing with the patient. So this technology helps in in combating all the complications which can occur. A 3D print should be used. Then in orthodontics, we all are aware of aligners. So rapid aligner production by progressive 3D printing physical models using a CBCT scans is very easy and can be done for smile designing. So this is how a trauma patient can be treated rather than bending the this wire. Take a 3D print, then wherever the trauma is there, the 3D print is going to tell you the trauma at site, and then you can bend the wire, and finally that bended wire you can put on the patient. That will save time, that will generate a tangible reconstruction to the patient, and it will reduce the trauma to the surgeon as well as to the patient. Then AI integration. This is the next horizon, the future trends. The AI models are being trained on daily basis using the equipment of radiologists, keeping the good radiologist in loop, and the data which is being given to the which is being fed to these softwares. The deep learning of the machines is being done, and using that, the automated segmentation and predictive data driven treatment planning, reducing the manual software time. We can easily use AI for diagnosis as well as treatment planning. Chairside printing. Till now, the 3D printing was being done in labs using a CAD CAM or a 3D printer. But now with ultra fast clinical resins curing for same day delivery, as I was telling you, the AI integrated dentures, same day delivery to the patient. So chair side 3D printing will be done, and the denture, implant oriented denture, will be given to the patient within 1 hour and without wasting the time of the patient as well as clinician. So this is the main problem with the CBCT machines which we used to face, that the patient is having metallic restorations or some restorations which used to give artifact. But with the latest softwares, the algorithms are such that all the artifacts are being removed. So again, in this we can see artificial ARA has been used, and the artifact removal algorithms are removing the artifacts completely so that the best of the diagnosis can be done. So this is the face scan and digital scan, and then there is going to be airway analysis video also. Please see it once. These are the modern CBCT machines which are being used with more developed hardware and softwares. It will just detect, take a scan of your face, design a smile for you, and then further the treatment planning. Even the orthognathic surgeries can be planned very precisely using these softwares. Similarly, airway analysis, we hear a lot about obstructive sleep apnea these days, that patient is having OSA and other airway problems. So easily with using these scans, we can detect the airway of the patient, that where it is obstructed, and accordingly treatment can be done. This is a major cause of roadside accidents and deaths and snoring in the patients. Whosoever is having airway trouble, they mostly suffer from orofacial pain, sleep disorders. So all these things, a diagnosis can be easily made using these airway analysis softwares. These are the color-coded softwares which can tell that where the blockage of the airway is taking place and why the patient is having difficulty in breathing. So the virtual patient synthesis, now see, we are closing the gap between the dental and the medical imaging through the help of this image. We can clearly see that where all the patient is having a difficulty in airway, and accordingly we can manage the patient by using the help of an ENT surgeon and a chest physician. Now, smile designing, again, face scan and aligners. Everything is being built using the CBCT scans. So this is the sequential planning in orthodontics, how the CBCT can help in developing the different aligners based on the treatment plan. Okay, now just an overview. So in diagnostic imaging advancements from CBCT to digital radiography, MRI, ultrasound, everything is coming into picture. Artificial intelligence and deep learning, in which there is automated detection, radiomics. Now I'll talk about radiomics in the end of my slides, and AI tools which are being used for the diagnosis. Radiomics is basically that with the help of certain AI inbuilt in the scans, we are able to detect, the AI is able to detect the places and diagnosis which the human eye can miss. Suppose I can miss that in this place a malignant change is taking place because it is very initial. But with the help of radiomics and AI tools, we will be able to detect it at a very early stage that yes, here the bony changes are taking place. This is not proper, and this is converting into some kind of bone malignancy, or some changes are taking place. Then interventional oral radiology, guided biopsy, silogogy, vascular procedures, various technologies, VR, AR, 3D printing, digital workflows. Then emerging frontiers in diagnosis of early caries, OCTs, photocounting, CT, liquid biopsy using your saliva. So CBCT, we have already talked about this. AI and deep learning. I was talking about radiomics, the quantitative extraction of image feature invisible to human eye for pathology characterization and malignancy risk. This is AI into diagnosis. This is known as radiomics. This is the next future which is coming in. Predictive AI, autocephalometrics, automated detections, teleradiology, MRI in dentomaxillofacial imaging for soft tissue imaging, especially for TMJ disc problems, wherever you feel that there is a patient of ADD with reduction, without reduction, there is so much going on TMJ and pain. So MRI has already come into play. There are various companies who are going to launch MRI, especially for the oro and maxillofacial imaging, which will have a sequence for diagnosis of malignant salivary gland tumors. MR neurography, MR equivalent to CBCT protocols is emerging, and it is going to be there soon. Even digital radiography, we have come to from D-speed films to PSP plates to modern CMOS sensors, which have real-time imaging, and the radiation exposure is very less. Also the subtraction radiography, so that you can easily do a follow-up of your patient, that how much the graft, after placing the graft, how much bone has, how much the healing has taken place. So high frequency ultrasounds, nuclear medicines, and hybrid imaging, in which you use two imaging, they are integrated together to diagnose a patient who is suffering from CA, and you want to stage the cancers for cancer staging and all these things. These are the latest in advances in maxillofacial imaging as well as general radiology, that how you are fusing the imaging, and with the help of fusion imaging, you are coming to a better diagnosis and better treatment planning. Interventional radiology in silogogy, TMJ, vascular interventions for all your vascular hemangiomas and all these things where you need embolization or you want to treat the patient. So with the intervention means not only you're diagnosing, you are at the same time you are treating the patient using the radiology part. So you will treat the patient also using the radiology part, that is interventional oral radiology. So virtual reality, the surgical simulation and training using CBCT data. So complex osteotomies, all these can be used. VR can be used here. Then augmented reality, that is AR. CBCT overlay on surgical field for real-time anatomical guidance. You can see the anatomy in real time. That is your AR. And VR is your basically the videography of the complete CBCT scan. Then 3D printing, then digital implant workflow, CAD/CAM integration, and teleradiology. This is the integration of technology and creating a digital workflow for surgery and patient care. So this is the latest which I have seen in various articles. The photocounting CT, ultra low dose CT is going to come. As you saw that it is the amount of radiation exposure is very high. Then optical coherence tomography. It is completely radiation free and it will help in early caries detection at enamel level only. So it is going to be a potential game changer for preventive dentistry. Then interproximal caries detection using transillumination, NIRT and DFOT are going to use. This is again going to be without radiation and fiber optic base. So already in early clinical adaptation. Then AI risk stratification, predicting the disease progression and treatment outcomes from the baseline imaging. So we are going to move from oral radiology into precision medicine using this AI risk stratification. So I had already told you AI is just going to help us and support us. Then liquid biopsy and imaging, integrating the salivary biomarkers with the radiographic features for a non-invasive oral cancer screening protocols is also going to be a next thing in 2030. This is definitely going to change how we are going to diagnose a patient of cancer. So the clinical bottom lines and key takeaway from 20 years at the forefront of oral radiology. So we can detect, quantify, predict, and intervene. This is going to be the next outcome of advancements in oral radiology. Radiation doses will be dropped. More than 80% radiation doses, we are going to cut off on the use of radiation. Then AI is now a clinical co-pilot. It is not the future, but it is the present already. Oral radiologists are no longer just going to be a diagnosticians. We are digital architects and proceduralists. Then multidisciplinary integration is the new gold standard across all specialties. So with this, I end my presentation. And I would only like to say that technology can enhance the precision, speed up the diagnosis, detect the subtle findings, and it can support the clinical decision making. But the human eye, the experience, the empathy, and clinical judgment will definitely remain irreplaceable. So the future is radiologist. It is not going to be radiologist versus AI. It is going to be radiologist plus AI and working together to make a diagnosis which is smarter, faster, and definitely it is going to be more accurate. So thank you, everyone. So just in case you have any questions, you can ask me.
Thank you, Dr. Punita Vora, ma'am, for such an insightful and enriching lecture. Your expertise and valuable perspectives have certainly added to our learning experience. We truly appreciate your time and contribution to the International Digital Dentistry Congress. Thank you once again for being a part of the International Digital Dentistry Congress 2026. We hope you have a wonderful and enriching experience ahead. Have a great day and we look forward to see you again. Thank you so much, everyone.